Have you ever paused to truly consider the astonishing complexity packed into the very genesis of human life?
hmm
It's this intricate, astonishing dance of biology and timing that often unfolds entirely out of sight, y- long before we even comprehend its beginnings.
Right.
For something so fundamental to our existence, the process itself remains largely a hidden marvel.
And that's precisely what makes the study of human pregnancy so profoundly compelling, I think. It's not just a collection of biological facts.
Ah.
It's a meticulously orchestrated, multi-stage process that transforms microscopic cells into a fully formed individual. Each step is, well, a testament to biological precision.
Absolutely. And that's exactly where we're headed today. This deep dive is designed as a comprehensive exploration of human pregnancy.
hmm
From that precise, almost miraculous moment of conception, through the intricate stages of fetal development, the astonishing transformations within the mother's body, and of course the crucial care that ensures a healthy outcome for both.
And our journey today is guided by a stack of foundational sources, really a collection of expert insights, research notes. They act as our detailed roadmap to the biological and physiological marvels of gestation.
Yeah.
We're looking beyond just the what to really understand the how and the why.
Our mission, then, is to unpack these intricate processes, revealing not just the well-known facts, but also the hidden wonders and, the deeper implications. We want to give you a truly holistic understanding.
Kind of like a shortcut.
Exactly. Think of it as your shortcut to being genuinely well-informed, offering those aha moments that genuinely connect the dots in surprising ways.
hmm
Okay, let's unpack this incredible journey from its very first spark. So we're starting our story at the absolute beginning with the genesis of life itself.
The very start.
The initial weeks, from conception through the earliest stages of embryonic development, are just packed with such astonishing precision. They truly lay the entire foundation for everything that follows. Okay, so it all kicks off with fertilization, a remarkably precise event, you said. And it typically takes place in the ampulla. That's the widest part of the fallopian tube.
That's right, the ampulla. And the timing here is incredibly critical. It really has to happen within about 24 hours of the ovum being released during ovulation.
Just 24 hours. Wow.
Yeah, it's a tight window for the egg. Sperm, on the other hand, they can remain viable in the female reproductive tract for, well, up to 5 days sometimes.
5 days. Quite a difference.
It is. But that ovum, it has a much narrower window of receptivity lasting only about 12 to 24 hours.
So this limited window for the ovum really emphasizes the absolute synchronicity required, doesn't it?
It absolutely does. And what's truly remarkable about this timing is it's evolutionary genius, you could say. This narrow window for fertilization essentially acts as a biological filter. It necessitates a high level of biological readiness and coordination from both male and female systems,
Right.
ensuring that only the most viable sperm present at the optimal moment actually have a chance to initiate a pregnancy. It's not just a race against the clock. It's a perfectly calibrated biological orchestration.
And the sperm itself.
Oh,
It isn't ready for its singular purpose the moment it enters the female reproductive tract, is it?
Yeah.
It has to undergo something called capacitation.
exactly. Capacitation. It involves enzymatic and membrane changes.
So for an organism designed for such a singular vital purpose, it's fascinating that it needs this additional prep time. What's the evolutionary advantage there?
Well, it's a sophisticated quality control mechanism, really. Capacitation ensures that only sperm that have spent sufficient time traversing the female reproductive tract, proving their endurance and viability,
Okay.
are actually primed to fertilize the egg. This prevents, premature activation of the sperm's acrosome.
The acrosome being.
That's the cap on the sperm head containing powerful enzymes. Capacitation ensures these enzymes are reserved for precisely the right moment when it's directly encountering the ovum's protective layers.
Got it. So once capacitated, what happens right at the egg's surface?
Okay, so once a capacitated sperm reaches the ovum, it triggers the acrosomal reaction.
Right.
This involves the release of specific enzymes like hyaluronidase and allocrisin from that acrosome.
Enzymes to break through.
Exactly. These enzymes are absolutely crucial for breaking down the ovum's outer protective layers, particularly the corona radiata and the robust zona pellucida.
And it's often a team effort. Lots of sperm helping out.
It often is, yes. Many sperm might contribute to the enzymatic breakdown of these barriers, even though ultimately only one will successfully penetrate. It's a testament to numbers and cooperation, even for a single victor.
Okay, here's where it gets really ingenious, I think. Once that single sperm manages to breach the ovum's defenses and enter, What happens?
Ah, yes. It triggers an immediate and critical cascade of events known as the cortical reaction. This is the ovum's rapid, almost instantaneous defense
Oh,
mechanism.
defense mechanism.
Yes. It hardens the zona pellucida and inactivates any remaining sperm receptors on the egg's surface. This effectively prevents polyspermy.
Polyspermy meaning multiple sperm getting in.
Exactly. The entry of multiple sperm. It's almost as if the egg slams the door shut and puts up an impenetrable no vacancy sign the moment the first guest arrives.
It makes you wonder how something so microscopically complex could have evolved such an efficient security system, doesn't it?
It truly is a masterstroke of natural selection. See, polyspermia would lead to an incorrect number of chromosomes, making the resulting zygote inviable.
Ah, okay. So it wouldn't survive.
Correct. So this foolproof mechanism is absolutely fundamental to safeguarding the correct genetic contribution and ensuring the viability of the new life.
So after the entry in the block,
Right. Following the successful entry in the polyspermy block, the male and female pronuclei, which are essentially the genetic material from each parent, finally fuse together.
a big moment.
This fusion marks the formation of the zygote, a single cell containing 46 chromosomes, the complete and unique genetic blueprint of a new, genetically distinct human individual.
Wow.
This moment is the true start of a unique life, a series of precisely timed events that, when you look at them all together, appear nothing short of miraculous given the sheer odds involved.
So we have this newly formed zygote, but its journey is far from over. It immediately begins a rapid series of cell divisions,
Cleavage.
while simultaneously embarking on this multi-day voyage. First, it becomes a morula, a solid ball of cells,
Perfect, a marula.
then transforms into a blastocyst. And this tiny developing embryo then travels from the fallopian tube, where it was conceived, down into the uterus.
That's path.
And this is where implantation typically begins, around day 6 post-fertilization, usually settling into the upper posterior uterine wall, because it's highly vascularized there.
Exactly. The upper posterior wall is ideal. But this journey from the fallopian tube to the uterus, it's incredibly delicate, and its timing is exquisitely sensitive.
Alsa.
The blastocyst needs to arrive at just the right moment when the uterine lining, the endometrium, is at its peak receptivity. It's all prepared by a complex hormonal interplay.
Thus it's too early or too late.
The window for successful implantation can be missed. It really highlights the immense biological coordination required.
And once it reaches the uterus, it's not just passively floating around, is it? There are specialized cells, trophoblast cells.
Yes, on the outer layer of the blastocyst, they play a critical active role in embedding it. They essentially burrow into the endometrium, which then transforms into what's known as the decidua basalis. This is the crucial anchoring process, establishing the very first physical and functional connection between the developing embryo and the mother's uterine wall.
That active anchoring is foundational.
It is. And it's also important to note that this process of implantation, where the blastocyst invades the uterine lining, can sometimes cause a phenomenon known as implantation bleeding.
Ah, right. I've heard of that.
It's often lighter and shorter than a typical menstrual period and can sometimes be a source of confusion for individuals who might not yet realize they're pregnant.
Because it might seem like a light period.
Exactly. But it's a normal, if sometimes unexpected, part of the early pregnancy journey, a direct consequence of the embryo establishing its home.
It's truly astonishing when you visualize this. Yeah. A microscopic cluster of cells, no bigger than a poppy seed, embarking on a multi-day journey, then actively digging in to establish its permanent home. It's a testament to the powerful, inherent drive for life and the precision of these cellular processes that unfold almost immediately after conception. Okay, so once that tiny embryo is anchored, an absolutely astounding organ begins to develop, the placenta.
Nature's master interface, as you called it, is perfect.
It grows from those trophoblast cells, formed in the chorion, and integrates deeply with the maternal decidua, and its functional circulation establishes really quickly, by the 3rd week.
Surprisingly fast, yes. By the 3rd week of gestation. Structurally, it's incredibly complex, featuring specialized lobules called cotyledons, which house intricate fetal vessels, and these finger-like projections called chorionic villi. That's where all the vital maternal-fetal exchange occurs.
It's basically the fetus's support system.
In essence, yes, a transient but full-service support system. It effectively serves as the fetus's lungs, kidneys, liver, and a powerful endocrine system, all in one,
Wow.
until those delicate fetal organs are mature enough to take over after birth. And what's even more remarkable is its adaptability to prioritize fetal needs.
And it's a hormonal powerhouse. Let's talk about HCG first, human chorionic gonadotropin.
The famous one.
We often associate it with pregnancy tests, but its role is far more profound, isn't it?
Right.
So HCG isn't just a pregnancy test indicator.
No, not at all.
It's the early pregnancy's critical life support signal,
That's a great way to put it. It maintains the corpus luteum in the ovary.
which produces progesterone.
Exactly. HCG keeps that progesterone production going until the placenta itself is mature enough to take over, typically around 10 weeks of gestation.
So it's like a biological signal saying, we're here to stay, get ready.
Precisely. It's a masterstroke of biological signaling. This rapid chemical commitment is a critical evolutionary adaptation, cementing the pregnancy even before the placenta is fully formed. Nature's foresight, really.
Okay, so progesterone is key early on. What else does the placenta produce?
Well, speaking of progesterone, its continuous production by the placenta later on is absolutely vital too.
Why is that?
It maintains the pregnancy by relaxing the uterine muscles, preventing premature contractions that could expel the embryo or fetus. Without adequate progesterone, sustaining a pregnancy would be incredibly difficult.
Makes sense. And estrogens.
Estrogens, also produced by the placenta, play a complementary role. They promote uterine growth and increase blood flow to the uterus, ensuring that the growing fetus receives an ample and continuous supply of nutrients and oxygen.
Then there's human placental lactogen, or HPL. This one's fascinating because it increases maternal insulin resistance.
Right.
That sounds counterintuitive, doesn't it? Why would you want the mother's cells to be less responsive to insulin?
It does sound odd at first, but it actually ensures that more glucose remains in her bloodstream and is therefore available for the fetus.
Ah, so it prioritizes the baby's fuel supply.
Exactly. This highlights a critical, often unseen maternal sacrifice. The mother's body adapts to guarantee the baby gets enough fuel, even if it means altering her own metabolic balance. It's a brilliant prioritization of fetal growth.
That HPL mechanism is a perfect example of the maternal body actively prioritizing fetal needs, even at a metabolic cost.
Absolutely. And beyond hormones, the placenta acts as the fetal respiratory system.
Fetal lungs, essentially.
For now, yes. It facilitates the efficient transfer of oxygen from the mother's blood to the fetus, and conversely moves carbon dioxide, a waste product, from the fetal blood to the mother's circulation where she then exhales it. Life-sustaining exchange.
And it doesn't stop there. Nutrition delivery, too.
Oh, yes. Comprehensive nutrition delivery. Efficiently transferring glucose, amino acids, fatty acids, essential vitamins directly to the fetus, ensuring all the necessary building blocks for growth are supplied. It's like a highly sophisticated, personalized catering service.
All inclusive for the baby.
Pretty much. And it performs crucial excretion, removing fetal waste products like urea and creatinine and shuttling them into the mother's system for her kidneys to process.
So the fetal kidneys away from home.
You got it. Furthermore, the placenta acts as a vital storage organ, accumulating essential reserves of iron, glycogen, and protein.
Building up reserves. Why?
These reserves are critical, especially in the later stages of pregnancy and immediately after birth. They provide a buffer as the newborn adapts to independent feeding and metabolism.
Okay, so all these complex functions rely on incredibly efficient placental circulation. How does that work?
Oxygenated blood, rich with nutrients from the placenta, travels to the fetus via a single umbilical vein.
One vein carrying oxygenated blood. That's backward from us.
It is. And once the fetus utilizes that oxygen and nutrients, the deoxygenated blood and waste products return to the placenta through two umbilical arteries.
Two arteries carrying deoxygenated blood.
Okay. This counterintuitive flow is perfectly designed for fetal life, optimizing the delivery of resources.
This specific circulatory pathway is absolutely crucial then.
It is. All these placental hormones and the efficient exchange mechanisms are intricately linked. They maintain the pregnancy, drive those dramatic maternal adaptations we'll get to, and ensure the continuous health and rapid growth of the fetus. A seamless, highly integrated system.
Connecting the fetus to this powerhouse organ, the placenta, is the umbilical cord the ultimate lifeline.
Absolutely.
Its structure is quite specific, typically two umbilical arteries carrying deoxygenated blood away from the fetus.
And waste products, yes.
And one umbilical vein delivering that oxygenated, nutrient-rich blood to the fetus.
That's the standard setup. And what's fascinating here is the sophisticated protection afforded by Wharton's jelly.
Wharton's jelly, what's that?
It's this specialized gelatinous substance that surrounds and meticulously cushions the vessels within the cord.
That's padding.
More than just padding. It's not just a simple conduit. It's a carefully engineered, resilient cable designed to withstand pressure. This cushioning is absolutely essential for preventing compression of the vessels.
Which would cut off blood flow.
Exactly. It could severely compromise blood flow and oxygen supply to the fetus, particularly during fetal movements or uterine contractions. Without Wharton's jelly, the cord could easily kink or get squashed, leading to potentially disastrous consequences.
Wow. And sometimes there are variations in the cord structure, right? Like only 2 vessels.
Yes, a 2-vessel cord, meaning only 1 artery and 1 vein, instead of the typical 2 arteries and 1 vein, is a variation that definitely warrants attention.
Is it always a problem?
Not always. Many babies with a 2-vessel cord are perfectly healthy. However, it is statistically associated with certain anomalies, often renal or cardiac issues.
Kidney or heart problems?
Potentially, yes. So this connection is important because it highlights how seemingly small anatomical variations can be critical diagnostic indicators, prompting further investigation to ensure broader developmental considerations are addressed.
Okay, so once this delicate new life is anchored and connected via the cord, it starts to create its own internal world, right? This protective, fluid-filled environment.
Yeah.
Amniotic fluid.
Mm-hmm.
And it's far more dynamic than just a simple cushion, isn't it? It's not just water.
Not at all. It's a complex cocktail containing water, certainly, but also electrolytes, proteins, carbohydrates, lipids, shed fetal cells, and even substances like vernix.
A cheesy coating.
Yes, vernix caseosa. And lanugo, the fine, downy hair, both produced by the fetus itself.
So what does this fluid actually do?
It serves multiple vital functions absolutely indispensable for healthy fetal development. First, it physically cushions the fetus from external trauma and impacts, like a shock absorber.
Oh.
It plays a critical role in thermoregulation, maintaining a constant optimal temperature for the developing baby, like a personal incubator.
Nice and warm.
Crucially, it promotes symmetric growth, allowing the fetus to grow uniformly without being compressed by the uterine walls. And it provides the space for essential fetal movement.
Why is movement so important?
It's vital for musculoskeletal development. Bones and muscles need that movement to develop properly. And finally, it acts as a reservoir for fetal waste before those excretory systems are fully mature.
So it's not just a passive buffer, it's an active, essential component of fetal life, like living in your own personal, perfectly temperature-controlled swimming pool.
That's a great analogy, and just as important as its presence are its potential abnormalities. Changes in amniotic fluid volume can be crucial diagnostic indicators, a real-time report card on fetal health.
How so?
For instance, oligohydramnios, that means too little fluid, defined as less than about 300 milliliters, is often a direct signal of potential fetal renal anomalies, kidney problems.
Kidneys.
Because the fetus's urine production is a primary and continuous contributor to the fluid volume. So if the kidneys aren't functioning optimally, the fluid volume will naturally drop. It's a direct link.
Okay, that makes sense. And what about too much fluid? Polyhydramnios.
Polyhydramnios, or more than about 2 liters of fluid, can signal other significant issues. It might indicate gastrointestinal anomalies in the fetus.
Like a blockage.
Potentially, yes, meaning the fetus isn't efficiently swallowing enough of the fluid, which is a normal, continuous process vital for regulating volume.
So they swallow the fluid too.
They do. Polyhydramnios can also be associated with maternal conditions, most notably poorly controlled diabetes mellitus.
So the fluid level tells a story.
It absolutely underscores a profound insight.
Yeah.
The amniotic fluid volume isn't just an external environment. It's a closed-loop system where the environment dynamically reflects the internal health of the fetus. It offers a non-invasive diagnostic window. This dynamic feedback loop between fetal urination, swallowing, and fluid volume is a cornerstone of fetal health assessment.
As the placenta and these incredible protective systems establish themselves, the fetus embarks on its truly incredible journey of internal growth and maturation. It's like watching a high-speed time-lapse of human development week by week.
It really is. Every system is undergoing profound transformations.
Within this journey, the fetal circulatory system is a masterpiece of adaptation. It features these brilliant bypass systems or shunts that are absolutely essential for life in the womb.
Critical adaptation.
There's the ductus venosus that carries oxygenated blood from the umbilical vein directly to the inferior vena cava, bypassing the liver mostly.
Largely bypassing the liver, yes, because the fetal liver isn't fully active in its adult metabolic functions yet.
Okay. Then there's the foramen oval, An opening between the heart's atria.
Yes, a direct opening between the right and left atria, allowing blood to bypass the non-functional lungs.
And finally, the ductus arteriosus.
A vessel connecting the pulmonary artery directly to the aorta, also diverting blood away from the lungs.
So these shunts are essentially detours. Why are they so important?
They are fundamental to fetal survival. In utero, the fetal lungs aren't involved in gas exchange. That's the placenta's job, remember?
Right.
Similarly, the liver's full metabolic and detoxification functions aren't yet required. So blood needs to efficiently bypass these organs.
To get the oxygen where it's needed most, like the brain.
Exactly. To ensure oxygenated blood from the placenta is primarily directed to the developing brain and other vital organs, rather than wasted on circuits that aren't fully operational yet. It raises that fascinating question. How does the fetus get any oxygen without using its lungs?
It's all thanks to this specialized placental fetal circulatory design with the shunts.
Precisely.
And what happens at birth is nothing short of revolutionary, with the baby's very first breath.
A truly dramatic physiological shift occurs.
The pulmonary resistance in the lungs dramatically decreases as they inflate with air.
Instantly. This swift change in pressure triggers a cascade of events leading to the functional closure of these shunts, rerouting blood flow to the now functional lungs and liver.
Here's where it gets truly transformative. That single, monumental first breath triggers a complete overhaul of the circulatory system.
It does, seamlessly transitioning from fetal to adult circulation in mere moments.
How do they close so quickly?
It's an immediate and profound transformation. The foramen ovale functionally closes because the pressure suddenly becomes higher in the left atrium compared to the right.
Pressure change snaps it shut.
Essentially. The ductus arteriosus closes rapidly in response to increased oxygen levels in the blood and a drop in certain hormones called prostaglandins. The ductus venosus also typically closes soon after birth.
So these closures aren't just structural.
No, they represent the baby's complete physiological commitment to independent life outside the womb.
It's like watching a highly sophisticated temporary infrastructure being seamlessly dismantled the moment the permanent system is ready to come online.
A perfect analogy. This rapid, coordinated closure of the shunts, precisely at the moment of birth, is a breathtaking example of biological engineering essential for the newborn's survival.
Okay, let's walk through some of the visible progress. The milestones throughout pregnancy are truly astounding, aren't they?
Week by week, critical changes happen.
Imagine this. At just 4 weeks, a tiny heart is already beating.
Incredible, isn't it?
Limb buds, the beginnings of arms and legs appear, and the embryo starts to take on that distinct C-shaped body. It's astonishing how quickly fundamental structures begin to form.
Then by 8 weeks, a remarkable amount of detail has emerged. Digits, fingers, and toes are fully formed.
Wow, by 8 weeks.
Facial features are becoming distinct and major blood vessels are complete.
Okay, moving on to 12 weeks.
By 12 weeks, the level of development allows for significant changes. The sex of the fetus can often be identified via ultrasound now.
Oh.
Nails are forming on the fingers and toes, and importantly, urine production has begun.
So the fetus is already contributing to the amniotic fluid by now.
Actively, yes. By 16 weeks, delicate scalp hair begins to appear, and meconium.
Meconium.
Ah.
That's the first stool.
Right, composed of shed cells and digestive secretions. It starts to accumulate in the intestines. It's an interesting early peek into a developing digestive system that's still primarily processing amniotic fluid.
And at 20 weeks, that's halfway.
Around 20 weeks, we see even more specialization. The fetus is now covered in vernix caseosa.
The protective waxy coating.
And lanugo, that fine, downy hair. This is also when quickening is often felt.
Quickening the first flutters.
Exactly. The first subtle fetal movements perceived by the expectant parent. For many, quickening transforms the abstract idea of a developing baby into a concrete, interactive reality. A truly profound connection.
I can imagine what happens next. 24 weeks.
Continuing that journey, by 24 weeks, the fetus's hearing is developing, allowing it to respond to sounds from the outside world.
So they can hear voices.
Likely, yes. And remarkably, the alveoli, the tiny air sacs in the lungs essential for breathing, are beginning to form. This is a critical step in preparing the lungs for air, developing senses and preparing for air.
Getting ready. And later on.
Fast forward to 31 weeks. Significant fat deposits are accumulating under the skin, contributing to the baby's plumper appearance and providing vital energy reserves for after birth. Central nervous system, CNS maturation, is progressing rapidly, laying the groundwork for complex functions after birth.
And finally getting close to term. 36 to 40 weeks.
Right. By 36-40 weeks, the fetus is typically plump, most of the lentigo has usually disappeared, and it has reached term maturity. Fully ready, physiologically speaking, for the challenges of independent life outside the womb.
These milestones beautifully reflect the increasingly complex functionality of the fetus, don't they? From basic circulation to sensory organs and preparing all the major systems.
Each stage builds perfectly upon the last, culminating in a fully formed human being ready to transition.
Beyond those visible milestones, there's this complex symphony of internal development playing out. Each system maturing, specializing, getting ready.
Exactly. Let's delve into some of those system specifics. The respiratory system, for example.
Yeah.
We mentioned alveoli starting to form around 24 weeks.
Yeah,
But the key player here is surfactant.
the surfactants.
It's a crucial lipoprotein mixture that prevents the air sacs from collapsing after each breath. Think of it like a coating that keeps balloons from sticking together when they deflate.
Ah, okay. Important for breathing air.
Critically important. It begins to be produced by around 24 weeks, but the lungs aren't generally considered mature enough for full independent breathing until approximately 35 weeks.
So that 35-week mark is key for lung maturity.
It's a critical marker for viability, yes. It determines the lung's readiness and is a major factor in caring for premature infants.
What about the heart? You said it starts beating super early?
The cardiac system is one of the earliest. A detectable heart rate by just 3 weeks of gestation. A tiny yet powerful pump establishing itself incredibly early.
Amazing. And the digestive system?
The gastrointestinal system also matures progressively. The fetus begins swallowing amniotic fluid as early as 10-12 weeks.
Swallowing the fluid they're floating in. Why?
It's essential for the development of the GI tract itself, and it also helps regulate that amniotic fluid volume we talked about. And as we mentioned, meconium starts forming in the intestines around 16 weeks.
Okay, kidneys.
The renal system becomes increasingly active. Fetal urine production contributes significantly to the amniotic fluid volume from about 12 weeks onwards.
Reinforcing that link again, low fluid might mean kidney issues.
Exactly, that oligohydramnios connection.
And the brain, the neurological system.
The neurological system is incredibly complex and remains vulnerable throughout the entire gestation period.
The whole time, not just early on.
The whole time. While basic reflexes begin to develop early, the central nervous system is continuously maturing, undergoing rapid growth and differentiation right up until birth and beyond. This is crucial. The brain is constantly developing, which is why protection from teratogens and ensuring optimal nutrition are paramount throughout the entire pregnancy.
Got it. What about the liver?
The hepatic system, or liver, starts storing glycogen that's stored energy and iron by 20-24 weeks.
Stockpiling nutrients.
Essentially, yes, stockpiling essential nutrients and energy reserves that the baby will draw upon immediately after birth. It provides a critical buffer during the transition to external feeding and metabolism.
Sometimes this incredible journey involves more than one passenger. Multi-fetal pregnancies, like
Right.
twins. Double the wonder, right?
Double the wonder, but they also introduce a unique set of developmental nuances and potential considerations for both the babies and the expectant parent.
Okay, so what are the types of twins?
We distinguish between two primary types, and the distinctions are really critical. First, dizygotic twins.
Fraternal twins.
Right, often called fraternal. They result from two separate ovaes being fertilized by two separate sperm. Genetically, they're as alike as any other siblings, just born at the same time.
And they usually have their own sacs and placentas?
Typically, yes. Separate placentas, separate chorions, the outer membrane, and separate amniotic membranes, the inner sac.
Okay, and the other type?
Monozygotic twins. These arise from a single fertilized ovum that splits into two.
Identical twins.
Exactly. And the timing of that split is profoundly crucial because it dictates their placentation and membrane structure.
How does the timing affect things?
Well, if the split occurs very early, say within the first 3 days post-fertilization, they might still have separate placentas and membranes, just like fraternal twins. We call that dichorionic diamniotic.
Okay.
However, if the split happens a bit later, between days 4 and 8, they usually share a single placenta but still have separate amniotic sacs. That's monochorionic diamniotic. This setup carries increased risks.
Sharing a placenta is riskier.
It can be, yes, because of potential blood vessel connections between the twins. An even later split, between days 8 and 13, can lead to them sharing both a placenta and an amniotic sac. Monochorionic, monoamniotic. That further elevates the risks.
Sharing everything.
Right. And if the split occurs even later, after about 13 days, it can result in conjoined twins.
Wow. So that timing is incredibly important.
It highlights the delicate nature of early embryonic development and its long-term implications.
And while it's double the joy for many, there are also inherently increased risks associated with multifetal pregnancies in general, aren't there?
Yes, these are important clinical considerations. The maternal system is supporting multiple individuals, which increases certain demands and potential complications.
Exactly.
Key risks include a higher incidence of preterm birth babies born before their organs are fully mature. This often leads to lower birth weights and associated health challenges.
Makes sense.
There's also an increased risk of cord accidents, especially in those monochorionic, monoamniotic twins, where the umbilical cords are in the same sac and can become tangled or compressed.
Oh, wow.
Additionally, conditions like twin-to-twin transfusion syndrome can occur in monochorionic pregnancies, where blood flow is unevenly distributed between the fetuses through those placental connections.
So one twin gets too much blood, the other too little.
Essentially, yes, it requires careful management. So, close monitoring and specialized care are therefore absolutely essential in these pregnancies.
Speaking of risks, we absolutely need to talk about teratogens. These are what exactly? Any agent that can cause developmental abnormalities.
That's right. An agent could be a substance, an infection, radiation that can disrupt normal embryonic or fetal development, causing birth defects.
And there's a particularly vulnerable time period.
Yes, the greatest risk period for teratogen exposure is surprisingly early. It's between 3 and 8 weeks of gestation.
Weeks 3 to 8. That's really early. Many people don't even know they're pregnant then.
Exactly. And this period coincides with a critical phase known as organogenesis.
Organogenesis. Organ formation.
Precisely. This specific window highlights the incredible sensitivity during early embryonic development when all the major organs, heart, brain, limbs, etc., are rapidly forming.
So exposure during this time can have major structural effects.
Profound and lasting structural effects, yes. Examples include things like alcohol, certain prescription drugs like some anticonvulsants, illicit drugs, a range of infections collectively known as TORCH.
TORCH. What's that stand for?
It's an acronym for toxoplasmosis, other, like syphilis, varicella, parvovirus B19, rubella, cytomegalovirus, and herpes simplex. Also, radiation exposure can be teratogenic.
And is the risk gone after 8 weeks?
The risk for major structural defects decreases significantly after organogenesis. However, the central nervous system, which continues to develop and mature significantly throughout the entire pregnancy,
Like we discussed.
remains highly vulnerable. So exposure later in pregnancy might lead to functional deficits, like developmental delays or behavioral problems, rather than obvious structural malformations.
So understanding this vulnerable window from week 3 to 8 and the ongoing CNS vulnerability is absolutely vital for anyone planning or experiencing a pregnancy.
Absolutely vital. It allows for crucial precautions, sometimes even before a positive pregnancy test is confirmed.
Right.
This profoundly underscores the importance of early prenatal care and comprehensive education for individuals of childbearing age. Knowing these risks allows for proactive measures.
Like avoiding alcohol, checking medications.
Exactly. Avoiding alcohol completely, discontinuing certain medications before conception if possible, or discussing all current and planned medications with a healthcare provider. It's all about mitigating potential harm during this incredibly sensitive foundational period, creating the safest possible environment even before the pregnancy is widely known. It really emphasizes proactive health decisions.
Okay, so while the fetus is undergoing its incredible journey of growth and maturation, the mother's body is simultaneously performing an astonishing feat of adaptation.
A complete overhaul, in many ways.
It's a complete symphony of physiological changes, meticulously preparing her for the growth of her baby and the incredible demands of childbirth and beyond. Let's start with the obvious place, the reproductive system, the uterus. It starts out pear-sized.
About 2 ounces, pear-sized, yes. And it undergoes a truly massive enlargement. Increases in size and weight hundreds of times to accommodate the growing baby, placenta, and amniotic fluid.
Hundreds of times. That's incredible.
It is. And this is accompanied by a dramatic increase in blood flow to the uterus, ensuring optimal nutrient and oxygen delivery.
And healthcare providers look for specific signs of these changes, right?
Yeah.
Like Goodell sign.
Right. Goodell's sign is the noticeable softening of the cervix, and Chadwick's sign is the bluish discoloration of the cervix and vaginal mucosa.
Why blue?
Both are caused by increased vascularity, significantly more blood flow to the area due to heightened estrogen levels.
Okay. And the mucus plug. That sounds protective.
It is. Another remarkable natural defense mechanism. A thick mucus plug forms in the cervical canal, acting as a crucial protective barrier against ascending infection from the vagina,
Seal it off.
essentially. Later in pregnancy, many women experience Braxton Hicks contractions.
The practice contractions, are they labor?
No, they're irregular, often painless contractions that help prepare the uterine muscle for labor, but they don't actually cause cervical dilation or effacement. Think of them as the uterus's warm-up routine.
Got it. What about the breasts? They change early too, right?
Yes, often quite early in pregnancy, significant changes occur in preparation for lactation. The areolae, the pigmented area around the nipple, darken.
Why do they darken?
The exact reason isn't fully known, but it might help the newborn visually locate the nipple. Also, the Montgomery tubercles.
Those little bumps.
Yes, small sebaceous glands around the nipples. They enlarge and secrete oils to provide lubrication and protection for the nipple during breastfeeding. And colostrum.
The first milk.
That's right, the nutrient-rich, antibody-packed first milk. It can often be present, sometimes even leak a little, as early as 16 weeks. It signals the body's remarkable readiness for nourishing the newborn.
Okay, now the cardiovascular system. You mentioned dramatic changes here.
Some of the most dramatic and essential adaptations happen here. First, blood volume increases by a staggering 40–50%.
40 to 50% more blood. Wow, why so much?
To meet the demands of the growing uterus and placenta, the developing fetus, and the mother's own increased metabolic needs. It also provides a reserve for blood loss during delivery.
And the heart has to pump all that extra blood.
Exactly. Correspondingly, cardiac output, the amount of blood the heart pumps per minute, increases significantly. Imagine your body circulating nearly half again as much blood. That's an immense undertaking, requiring the heart to work considerably harder.
That leads to something called physiologic anemia.
Yes, because the plasma volume, the liquid part of the blood, increases more than the red blood cell mass increases, so the red blood cells get diluted.
So it's not a true lack of iron, necessarily.
Not necessarily, although true iron deficiency anemia can also occur and needs to be monitored. But physiologic anemia is this hemodilution effect. The concentration of red blood cells in the expanded plasma decreases, even if the total number is okay or slightly increased.
Okay, and the blood itself changes. It clots more easily.
Yes, there's a significant increase in various clotting factors, leading to a hypercoagulable state.
Why would the body do that?
It's the body's natural adaptive preparation for childbirth. It's designed to reduce the risk of excessive bleeding or hemorrhage during and after delivery.
But it also increases the risk of blood clots.
That's the downside, yes. It makes pregnant individuals more susceptible to conditions like deep vein thrombosis, DVT, or pulmonary embolism, a critical consideration for care providers.
Another cardiovascular point, supine hypotension. Lying flat on your back is bad.
It can be, yes. Supine hypotension occurs when a pregnant person lies flat on their back, especially later in pregnancy. The heavy uterus compresses the inferior vena cava.
The big vein returning blood to the heart.
Exactly. This significantly reduces venous blood return to the heart, which can lower blood pressure and make the person feel dizzy, nauseous, and potentially reduce blood flow to the baby.
So lying on the side is better.
Emphasizing positional changes, like lying on the left side, is crucial to prevent this and ensure adequate circulation for both mother and baby.
Okay. Moving on to the respiratory system, changes there too.
Considerable adaptations. There's an increased need for oxygen to support both maternal and fetal metabolism. This leads to a mild chronic state of hyperventilation, breathing slightly deeper and faster.
So you take in more oxygen and blow off more CO2.
Precisely. Also, as the uterus grows, it pushes upward, elevating the diaphragm.
Making it harder to take deep breaths.
Yes, it can cause shortness of breath, often called dyspnea, even with mild exertion. A common and often uncomfortable symptom, especially later in pregnancy.
And the renal system. Kidneys working overtime.
They are. The kidneys experience a significant increase in glomerular filtration rate, GFR. That's the rate at which they filter blood, to handle the increased waste products from both the mother and the fetus. This increased filtration also leads to increased fluid retention overall, which helps support that expanded blood volume we talked about.
And sometimes sugar shows up in the urine. Glycosuria.
Yes, it's relatively common to see mild glycosuria in pregnancy. Even with normal blood sugar levels, the increased GFR can overwhelm the kidney's ability to reabsorb all the filtered glucose.
Interesting. What about the skin? Lots of visible changes there.
The integumentary system often displays some of pregnancy's most visible badges of honor, as you called them earlier.
And like the linea nigra.
Yes, the linea nigra, that dark vertical line that often appears on the abdomen running from the pubic bone up towards the belly button or higher. Also melasma.
The mask of pregnancy.
Right. Darkened patches of skin, usually on the face, forehead, cheeks, upper lip. Both linea nigra and melasma are caused by hormonal stimulation of melanin production.
And stretch marks. Stria gravidarum.
Very common, yes. As the skin on the abdomen, breasts, hips, and thighs stretches rapidly to accommodate growth, these are fascinating visible manifestations of the body's remarkable transformation.
Yeah. Now, musculoskeletal. Back pain seems almost universal.
It's very common. The growing uterus shifts the center of gravity forward. To compensate, there's an increased inward curvature of the lumbar spine that's called lordosis.
Sway back posture.
Exactly, and that can be a significant cause of lower back pain. Also, hormones, particularly one called relaxin.
Relaxin. Does what it sounds like.
Pretty much. Relaxin causes softening and relaxation of pelvic joints and ligaments.
To prepare for delivery. Make the pelvis more flexible.
That's the primary purpose, yes. But it also contributes to common aches and pains, particularly in the hips, sacroiliac joints, and lower back, as the body's structural stability is temporarily altered. Things feel a bit looser.
Okay, last system. Gastrointestinal. The source of many familiar discomforts.
Indeed. Nausea and vomiting, especially in the first trimester, morning sickness, though it can happen anytime.
Caused by hormones.
Largely driven by hormonal changes, particularly rising HCG levels, yes. Also, constipation is common due to slowed GI motility. The muscles of the digestive tract relax because of progesterone.
And reflux or heartburn.
Very common, too. Caused partly by hormonal changes relaxing the esophageal sphincter, the valves between the esophagus and stomach, and partly by the growing uterus physically pushing up on the stomach.
Makes sense. And pica. Those weird cravings.
Yes, pica, abnormal cravings for non-nutritive substances like ice, clay, dirt, or laundry starch. It's often, though not always, linked to an underlying nutritional deficiency, particularly iron deficiency anemia. It requires investigation.
And all these profound changes.
Yeah.
They're fundamentally driven
by the complex interplay of placental hormones we talked about earlier, HCG, progesterone, estrogen, HPL. They orchestrate this entire symphony of maternal adaptations, ensuring the pregnancy can be sustained and fetal development optimally supported.
To help us understand and monitor this incredible journey, pregnancy is traditionally divided into 3 distinct trimesters.
Convenient benchmarks.
The first trimester is from conception through 13 weeks. The second trimester runs from 14 to 27 weeks, and the third trimester is from 28 weeks until birth.
Right.
And these aren't just arbitrary divisions, are they? They reflect distinct developmental stages for the fetus and significant physiological shifts for the mother. They really guide clinical care and expectations.
Absolutely. And we also categorize the signs of pregnancy based on how reliable and objective they are.
Okay, like presumptive signs.
Presumptive signs are subjective. They're experienced and reported by the woman herself. They include things like amenorrhea, the absence of menstruation.
The most common early sign.
Usually. Also, nausea and vomiting, profound fatigue, urinary frequency, breast tenderness, and eventually quickening those first fetal movements.
But these aren't definitive proof.
No. While highly suggestive, these are subjective and can sometimes have other causes, so they're presumptive, not positive.
Okay, then we have probable signs, more objective.
Exactly. Probable signs are objective indicators observed by an examiner, but still not 100% definitive proof of pregnancy.
Like?
These include Goodell's sign, the softening of the cervix we mentioned, Chadwick's sign, that bluish discoloration, Hagar's sign, a softening of the lower uterine segment, felt on bimanual exam, changes in uterine size and shape, and, importantly, a positive human chorionic gonadotropin HCG pregnancy test.
Wait, a positive pregnancy test is only probable, not positive.
Technically, yes. While a positive HCG test is a very strong indicator, in very rare circumstances, other conditions can cause elevated HCG. So it falls under probable.
Okay. So what are the positive signs, the absolute proof?
The truly positive signs are the irrefutable proof. There are 3 main ones.
Yeah.
Direct observation of a fetal heartbeat detected by an examiner using a Doppler or fetoscope.
2.
Fetal movement felt or palpated by an experienced examiner.
In 3.
Direct visualization of the fetus via ultrasound. Seeing the baby on the screen.
Those leave no room for doubt.
None whatsoever.
And speaking of those positive HCG tests, modern pregnancy tests are incredibly sensitive now, aren't they?
They really are. They're designed to detect human chorionic gonadotropin, HCG. Serum HCG tests, which use a blood sample, are the most sensitive.
How early can they detect pregnancy?
They can often detect HCG as early as 7 to 8 days after ovulation, frequently before a missed period even occurs.
Wow, that's early.
It is. Urine tests, the home pregnancy tests, are generally less sensitive and are typically accurate closer to the time of a missed period, although some newer ones are getting more sensitive too.
It just showcases the incredible sensitivity and continuous advancement of modern diagnostic tools, allowing for very early confirmation.
It really does.
Navigating pregnancy effectively really relies heavily on two key things: comprehensive prenatal care and optimal maternal nutrition.
The essential blueprint for a healthy journey.
Exactly. This combination minimizes risks and promotes optimal development for both mother and baby.
Okay, first, healthcare providers use a specific set of terms to describe someone's obstetric history, like gravida and parity.
Yes, it provides a universal language for clear, concise communication in a clinical setting. So, gravida is.
Gravida refers to the total number of times an individual has been pregnant, regardless of the outcome or duration. Includes current pregnancy.
Got it. And parity.
Parity refers to the number of pregnancies that have reached 20 weeks of gestation or beyond. It doesn't count the number of babies, just the number of pregnancies reaching that viability point.
Okay. And within parity, there are more details, right? Like term, preterm.
Correct. Parity is often broken down further using the TPL system or similar variations. T stands for term pregnancies, those reaching 37 weeks or more. P is for preterm pregnancies ending between 20 weeks and 36 weeks and 6 days. A is for abortions pregnancies ending before 20 weeks, whether spontaneous, miscarriage, or induced. And L is for living children.
So TPL gives a very detailed picture.
It does. These terms provide a standardized language that allows healthcare providers to quickly understand a patient's obstetric history and tailor care accordingly.
Okay, let's talk about the actual care. The initial prenatal visit seems really important.
It's arguably the cornerstone of all subsequent care. It really establishes the entire framework.
What happens at that first visit?
It involves a thorough personal and family medical history, obstetric history, social history, a complete physical examination including pelvic exam, and a comprehensive panel of laboratory tests.
What kind of lab tests?
Typically a complete blood count, CBC, blood type and Rh factor screening, antibody screening to check for antibodies that could affect the baby, screening for sexually transmitted infections, STIs like syphilis, chlamydia, gonorrhea, rubella immunity status, hepatitis B and C screening, and HIV testing. Urine culture, too.
And often an early ultrasound.
Yes, an early ultrasound is often performed for accurate dating of the pregnancy, confirming it's in the uterus, and assessing viability, checking for a heartbeat.
Plus education.
Absolutely. Crucial education is provided on topics like nutrition, safe medications, lifestyle adjustments, exercise, environmental hazards, and, very importantly, recognizing warning signs that need immediate attention.
So this initial visit really lays the groundwork for personalized care and risk assessment.
Exactly. Identifying any potential issues early allows for timely intervention and planning.
And once that initial visit is done, there's a pretty standard schedule for routine follow-up visits, right? Assuming it's a low-risk pregnancy.
Yes. The frequency of visits progressively increases as pregnancy advances, reflecting the escalating monitoring needs.
What's the typical schedule?
Generally, for a low-risk pregnancy, visits are scheduled every 4 weeks until about 28 weeks of gestation, once a month. Then, from 28 to 36 weeks, the visits become more frequent, usually shifting to every 2 weeks.
Okay.
And finally, from 36 weeks until birth, they are typically weekly.
Why the increase?
This increasing frequency allows for closer monitoring of both maternal well-being, like blood pressure, and fetal well-being, like growth and position, as the due date approaches and the body prepares for labor. It helps catch potential problems like preeclampsia or fetal growth issues earlier.
And specific lab tests are often done at different points too, right? Timed strategically.
Yes, ensuring timely screening and intervention. In the first trimester, besides the initial labs, genetic screening options are discussed and offered.
Like neutral translucency ultrasound and blood tests.
Exactly. Carrier screening might also be done based on ethnicity or family history. Initial STI screening, urine analysis, and often an updated pap smear if due. Early screening is crucial here for identifying potential risks, offering intervention or further testing, and providing reassurance.
Okay. What about the second trimester?
Moving into the second trimester, common tests include the quad screen or other serum screenings for chromosomal abnormalities and neural tube defects, typically done between 15-20 weeks.
Uh-huh.
And the big one, the detailed anatomy scan ultrasound.
Around 18-20 weeks, what are they looking for?
Yes, typically 18-20 weeks. This is where we get a comprehensive, detailed look at fetal development, examining all major organ systems, brain, heart, spine, limbs, kidneys, etc., to ensure they are forming correctly and identifying any potential structural anomalies. Placenta location and amniotic fluid are checked, too.
A very thorough checkup.
Extremely thorough and important.
And by the third trimester, a whole new set of important screenings.
Indeed. The third trimester involves screening for gestational diabetes, usually with a glucose tolerance test, GTT, around 24-28 weeks.
Checking how the body handles sugar.
Right. Another Rh antibody screen is done if the mother is Rh negative to make sure no sensitization has occurred. A repeat hemoglobin hematocrit, HH, checks for late pregnancy anemia. STI rechecks are often performed depending on risk factors.
And Group B strep, GBS.
Yes, very important. A Group B strep GBS vaginal rectal swab is routinely done between 35 and 37 weeks.
Why is that one so important?
GBS is a bacteria commonly found in adults that usually doesn't cause harm, but if a mother carries it, she can pass it to the baby during delivery, potentially causing serious infection like sepsis or meningitis in the newborn.
So if the test is positive.
If positive, antibiotics are administered intravenously during labor to prevent transmission to the baby. It's a highly effective preventative measure.
Got it. And during these routine visits, they measure fundal height.
Yes, a simple yet effective way to track fetal growth and estimate gestational age.
How does that work?
From about 20 to 36 weeks, the measurement in centimeters taken from the top of the pubic bone to the top of the uterus, the fundus, generally correlates directly with the gestational age in weeks, plus or minus about 2 centimeters.
So at 28 weeks, it should be around 26 to 30 centimeters.
Exactly. It's a basic but reliable screening tool to help ensure the baby is growing on track. A significant discrepancy might prompt an ultrasound for a closer look. Hashtag tag 4.2, managing common discomforts and recognizing warning signs.
Pregnancy, while amazing, definitely comes with its share of common discomforts. Thankfully, many are manageable.
Yes, many are, with simple strategies based on understanding the physiological changes.
Like for nausea and vomiting, morning sickness.
Frequent small, bland meals or snacks can help keep blood sugar stable and the stomach from getting empty. Avoiding triggers like strong smells, ginger in various forms like tea, candies, capsules can often provide relief. Sometimes medication is needed if it's severe.
Heartburn, that upward pressure.
Eating smaller meals, avoiding greasy or spicy foods, and staying upright for a while after eating can help. Sleeping slightly elevated. Antacids are often safe and effective too.
Constipation, from that slowed motility.
Increasing dietary fiber, fruits, veggies, whole grains, drinking plenty of fluids, and regular physical activity are key. Stool softeners might be recommended if needed.
Back pain from the lordosis and relaxin.
Maintaining good posture, wearing supportive low-heeled shoes, using proper body mechanics when lifting, sleeping with pillows for support, pelvic tilt exercises, and sometimes a maternity support belt can be beneficial. Prenatal massage or physical therapy can also help.
And those lovely leg cramps, especially at night.
Stretching the calf muscle by dorsiflexing the foot, pulling the toes up towards the shin can help relieve an acute cramp. Ensuring adequate hydration and sometimes calcium or magnesium supplementation might be suggested by a provider, though evidence is mixed.
So these aren't just minor annoyances. Addressing them really improves quality of life.
Absolutely. Managing these common discomforts can make a substantial difference in daily well-being during pregnancy.
However, it's equally, if not more, important to recognize critical warning signs that need immediate attention, right? Things that aren't normal discomforts.
Critically important. Knowing when something needs urgent medical evaluation is crucial.
Like what? What are the red flags?
Any vaginal bleeding more than light spotting, especially if accompanied by pain. Rupture of membranes, a gush or continuous trickle of clear fluid from the vagina.
Water breaking.
Yes. A noticeable decrease or absence in fetal movement compared to the baby's usual pattern. Severe or persistent headache, especially if accompanied by vision changes, blurriness, spots, flashing lights, or severe upper abdominal pain. These could be signs of preeclampsia.
Preeclampsia, high blood pressure condition.
Yes, a serious condition involving high blood pressure and often protein in the urine or other organ issues. Also, any signs of preterm labor before 37 weeks, regular painful contractions, constant low backache, pelvic pressure, or increased vaginal discharge. Swelling, especially sudden swelling of the face or hands, persistent vomiting preventing keeping liquids down, fever or chills, painful urination.
So this raises the critical question. Knowing precisely when to call the doctor or midwife or go to the hospital is absolutely vital.
It is. Timely intervention for these warning signs can prevent serious complications and profoundly impact the well-being and safety of both mother and baby. Never hesitate to call if you're concerned.
Maternal nutrition, paramount during pregnancy. You really are fueling two lives.
Absolutely. What the mother eats directly impacts fetal growth and development as well as her own health.
Let's talk weight gain first. The recommended goals are personalized, based on pre-pregnancy weight.
Yes, based on the individual's pre-pregnancy body mass index, BMI. It's not a one-size-fits-all number.
So for someone starting underweight,
Underweight, BMI 18.5, the goal is typically 28-40 pounds.
normal weight.
Normal weight, BMI 18.5, 24.9. The recommendation is 25-35 pounds.
Overweight.
Overweight, BMI 25, 29.9. It's advised to gain 15-25 pounds.
And for someone starting with obesity?
Obese, BMI or 30, the goal is generally 11-20 pounds.
And the pattern matters too, not gaining it all at once.
Right. The pattern typically involves gaining only about 4.5 pounds total in the first trimester, followed by a steadier gain of roughly 1 pound per week thereafter for those starting at a normal weight. The rate varies based on the starting BMI category. These are personalized targets, aiming for healthy growth without excessive gain.
Okay, calories. It's not really eating for two in terms of quantity, is it?
Not in the sense of doubling portions, no. It's about eating smart for two, focusing on nutrient-dense foods. Calorie needs do increase, but moderately.
How much?
Generally, no extra calories are needed in the first trimester. In the second trimester, needs increase by approximately 340 kilocalories a day.
About an extra snack, maybe?
Pretty much, like yogurt and fruit, or half a sandwich. And in the third trimester, the increase is about 450 kcal a day compared to pre-pregnancy needs.
And protein. That's important for building tissues.
Very important. Protein intake recommendation increases significantly to about 71 grams per day to support the rapid fetal growth, development of the placenta, expansion of maternal tissues like the uterus and breasts, and the increased blood volume.
So focusing on good protein sources is key. What about micronutrients, vitamins and minerals?
Certain micronutrients are absolutely essential and have increased needs during pregnancy. Folic acid, or folate, is critical.
For preventing neural tube defects.
Exactly, like spina bifida. The recommendation is 600 micrograms per day, ideally starting before conception, as the neural tube closes very early. That's why prenatal vitamins are so important.
Iron, for that increased blood volume.
Yes, iron needs jump to 27 milligrams daily to support the increased maternal red blood cell mass and provide iron to the growing fetus and placenta. Preventing iron deficiency anemia is crucial.
Calcium, for bones.
Calcium, 1,000 milligrams per day, same as non-pregnant adults, but crucial to meet, is vital for fetal bone and teeth development. If maternal intake is low, calcium will be drawn from her bones. Vitamin D, 600 IU or more, needs vary, aids in that calcium absorption.
And the others that are key.
Iodine, 220 micrograms daily, is important for maternal thyroid function and, critically, for fetal brain development. Choline is also increasingly recognized as important for brain development. DHA, an omega-3 fatty acid found in fish, is vital for fetal brain and eye development too.
So a balanced diet plus a prenatal vitamin usually covers these.
Generally, yes. A good prenatal vitamin is designed to supplement a healthy diet and meet these increased needs.
And hydration. Fluids.
Also paramount. Aim for about 8-10 cups, around 2.3 liters of total fluid per day. Water is best to support increased blood volume, amniotic fluid production, and metabolic processes.
Okay, now the important part. Foods to avoid or limit.
Yes, and the rationale behind these restrictions is crucial for safety.
Like high mercury fish.
Right. Avoid fish high in mercury, like shark, swordfish, king mackerel, and tilefish, due to potential neurotoxicity to the developing fetal brain. Limit albacore tuna. Lower mercury options like salmon, light tuna, shrimp, and cod are good choices for DHA.
Unpasteurized foods.
Avoid unpasteurized milk, cheeses, like soft cheeses such as feta, brie, queso fresco unless clearly made with pasteurized milk, and juices. These can harbor harmful bacteria, particularly Listeria.
Listeria is a big concern.
Yes, Listeria infection during pregnancy can be very serious, potentially causing miscarriage, stillbirth, or severe illness in the newborn. Also, avoid raw or undercooked eggs, risk of salmonella, and raw sprouts.
Deli meats, cold cuts.
Deli meats and hot dogs should be avoided unless heated until steaming hot just before serving, again due to the risk of listeria contamination after processing.
Alcohol.
Alcohol has a zero-tolerance policy during pregnancy. There is no known safe amount or safe time to drink alcohol. It can cause fetal alcohol spectrum disorders, FASDs, leading to lifelong physical, behavioral, and intellectual disabilities.
So 0 alcohol and caffeine.
Excess caffeine should be limited. Current recommendations generally suggest keeping intake below 200 milligrams per day, about the amount in one 12-ounce cup of coffee.
The overarching rationale here is minimizing exposure to harmful bacteria, parasites, and toxins that can cross the placenta.
Exactly. And basic food safety is vital too. Wash fruits and vegetables thoroughly. Cook all meats, poultry, and fish to safe internal temperatures to kill potential pathogens like Toxoplasma or Salmonella.
And that Pica thing again, the non-food cravings, linked to anemia.
Often linked to iron deficiency anemia, yes. It's an unusual craving, but can be a physiological signal that requires investigation and treatment of the underlying deficiency.
An important part of prenatal care that sometimes gets overlooked is vaccinations, protecting both the mother and the baby.
Absolutely. It's not just about preventing maternal illness. It's also about providing passive immunity, transferring the mother's antibodies to the newborn, protecting them in their first vulnerable months.
So what vaccines are safe and recommended during pregnancy?
The inactivated flu shot is recommended for everyone during flu season, regardless of trimester. It protects both mom and baby.
Okay.
The Tdap vaccine is crucial. It protects against tetanus, diphtheria, and pertussis whooping cough.
When is Tdap given?
It's recommended during each pregnancy, ideally between 27 and 36 weeks. This timing maximizes the antibody transfer to the fetus, providing critical protection against whooping cough, which can be life-threatening for young infants.
So even if you had it before, you get it again each pregnancy.
Yes, to boost those antibodies for transfer each time. The COVID-19 vaccine is also recommended during pregnancy, and the newer RSV vaccine can be given seasonally between 32 to 36 weeks to protect the baby from severe RSV illness after birth.
Okay, those are the recommended ones. What about vaccines to avoid?
The key distinction is live versus inactivated vaccines. Live attenuated vaccines, which use a weakened form of the virus, are generally avoided during pregnancy.
Why? Is there a risk?
There's a theoretical, albeit small, risk of transmitting the weakened virus to the fetus. So, out of an abundance of caution, they are contraindicated.
Which ones are live vaccines?
This category includes the MMR, measles, mumps, rubella vaccine, the varicella chickenpox vaccine, and the live attenuated intranasal flu vaccine, the nasal spray. These should ideally be given before pregnancy if needed.
So understanding the distinction live versus inactivated is crucial for making informed decisions.
Vital, yes. Balancing the clear benefits of recommended immunizations with avoiding even theoretical risks from live vaccines.
As we move closer to birth, monitoring the miracle becomes even more critical. This involves precise fetal assessment both during the course of pregnancy and, even more intensely, during labor.
And understanding specific considerations for pregnancies identified as high risk.
During labor itself, closely monitoring fetal well-being is paramount, primarily through assessing the fetal heart rate, FHR, and uterine contractions rate.
Absolutely. The goal is to ensure the fetus is tolerating the stress of labor and receiving adequate oxygenation.
What are the main ways this is done?
There are two main methods. First, intermittent auscultation.
Listening periodically.
Yes, involves periodically listening to the fetal heart rate, often using a handheld Doppler or a fetoscope, typically after a contraction for a full minute. This method is suitable for low-risk pregnancies and offers the great benefit of allowing for greater maternal mobility during labor, walking around, changing positions easily.
And the other method.
Continuous electronic fetal monitoring, or EFM. This uses external sensors, one for FHR, one for contractions, or sometimes internal monitors placed after membranes rupture.
And this provides constant data.
Yes, a continuous printout or screen display of both the fetal heart rate and the uterine activity pattern. This is typically used for higher-risk pregnancies, if pitocin is used for induction or augmentation, or if any concerns arise about fetal well-being during labor based on intermittent checks.
So the choice depends on the situation and risk level.
Exactly. It's tailored to the individual needs and risk profile.
Okay, let's talk about what the EFM shows. Uterine activity first. What's normal?
For uterine activity, we look at frequency, duration, intensity, and resting tone. A normal pattern during active labor is typically 5 or fewer contractions in a 10-minute period, averaged over 30 minutes.
What if there are more than 5 contractions in 10 minutes?
That's termed tachysystole, and this raises that important clinical question. Why do too many contractions put the baby at risk?
Why?
It's because tachysystole significantly reduces the crucial rest time between contractions. During a contraction, blood flow through the placenta to the baby is temporarily reduced. The baby relies on that rest period between contractions to get fully reoxygenated.
So too many contractions mean not enough recovery time.
Exactly. Limited rest restricts the period of oxygen flow, potentially leading to decreased fetal oxygenation and distress over time. It needs careful management, sometimes by reducing pitocin if it's being used.
Okay, now the fetal heart rate, FHR itself, what's the normal baseline range?
The baseline FHR is the average rate during a 10-minute segment, excluding accelerations or decelerations. A normal baseline is between 110 and 160 beats per minute.
Faster than an adult's resting heart rate.
Significantly faster, yes.
And within that baseline, you mentioned variability is really important.
Variability is perhaps the most critical and subtle indicator of fetal well-being and oxygenation on the EFM strip.
What is variability exactly?
It refers to the fluctuations in the FHR around the baseline. We look at the amplitude of those fluctuations. Moderate variability fluctuations between 6 and 25 beats per minute amplitude is considered the reassuring sign.
What does moderate variability tell you?
It's considered a sign of good oxygenation and a healthy, mature, responsive fetal nervous system. It tells us that the baby's brain and heart are well oxygenated and interacting appropriately. The push-pull between the sympathetic and parasympathetic nervous systems is working well.
And if variability is low or absent,
Absent variability, undetectable fluctuation, or minimal variability, less than 5 beats per minute fluctuation, can be a concerning sign. It might indicate possible hypoxia, low oxygen, fetal acidosis, effects of medications given to the mother, or fetal sleep cycles, which are usually temporary. It warrants close attention and investigation. Marked variability over 25 BPM is less common, but also needs assessment.
so variability is like a window into the baby's nervous system health.
A very important window, yes. It's a critical, dynamic indicator of the baby's physiological state in real time.
Okay, besides baseline and variability, we also look for specific changes in the FHR pattern in relation to contractions, decelerations.
Right, periodic or episodic changes. Accelerations, temporary increases in FHR are usually reassuring signs of fetal well-being. Decelerations, temporary decreases, are categorized based on their shape, timing relative to contractions, and duration.
Like early decelerations.
Early decelerations are gradual decreases in FHR that mirror the contraction they start when the contraction starts, reach their lowest point, nadir, at the peak of the contraction, and return to baseline as the contraction ends.
What causes those? Are they bad?
They are usually benign. They're typically caused by fetal head compression as the baby descends through the birth canal. This triggers a vagal nerve response, slowing the heart rate temporarily. It's a common physiological response and generally not a sign of distress. No intervention is usually needed.
Okay. What about variable decelerations?
Variable decelerations are abrupt drops in FHR down and back up quickly, often looking jagged or V-shaped or U-shaped on the strip. Their timing relative to contractions is, well, variable. They don't consistently mirror them.
What causes variables?
These are typically caused by umbilical cord compression.
The cord getting squeezed.
Yes, which can quickly compromise oxygen flow if severe or prolonged. Interventions often focus on relieving that pressure.
Like changing the mother's position.
Exactly. Repositioning the mother, side to side, hands and knees, is often the first step. Sometimes supplemental oxygen for the mother or an amnio infusion,
Amnioinfusion.
where sterile fluid, like saline, is instilled into the uterus through a catheter after membranes have ruptured. This can help cushion the cord and reduce compression.
Okay, now late decelerations, you said these are more concerning.
Yes, late decelerations are generally considered more ominous. Like early decels, they're usually gradual decreases, but their timing is key. They begin after the contraction has started, reach their nadir after the peak of the contraction, and don't return to baseline until after the contraction has ended. There's a lag.
Why is that timing bad? What does it suggest?
It suggests uteroplacental insufficiency, meaning the placenta isn't delivering enough oxygen to the fetus to withstand the stress of the contraction. The baby's oxygen reserves dip, and the heart rate drops after the contraction stress is peaking or over.
Not good. What's the management for lates?
Management focuses on improving placental perfusion and fetal oxygenation rapidly. It often follows the Lyon mnemonic for intervention:
Yeah.
Position the mother on her left side or right side to improve blood flow by taking pressure off the vena cava.
Right.
Increase Farabi fluids, a bolus, to improve maternal hydration and blood volume.
Yeah.
Administer oxygen to the mother via mask, though the benefit is debated unless mom is hypoxic, it's often still done.
Yeah.
Notify the provider immediately for urgent evaluation. They may also consider decreasing or stopping pitocin if it's running and assessing for underlying causes. Persistent late decelerations are a sign of potential fetal distress and may necessitate expedited delivery.
Okay, that's clear. What about a prolonged deceleration? That sounds serious too.
It is. A prolonged deceleration is a significant drop in FHR, at least 15 beats per minute below the baseline that lasts for more than 2 minutes, but less than 10 minutes.
Longer than a typical decel, but not a total baseline change yet.
Right. If it lasts 10 minutes or more, it's considered a baseline change. Prolonged decels are critical events requiring urgent evaluation and intervention as they indicate a significant disruption in fetal oxygenation, possibly from cord prolapse, maternal hypotension, uterine tachysystole, or placental abruption. Immediate efforts are made to identify and correct the underlying cause.
Wow. So interpreting these patterns requires expertise.
It does. And to provide a clear, standardized classification system for swift action in these high-stakes moments, these FHR patterns are often grouped into NICHD categories, a 3-tier system.
Category 1.
Category 1 is normal and strongly predictive of normal fetal acid-base status. Reassuring. Baseline 110-160, moderate variability, no late or variable decels, early decels, okay.
Category 3. Jump to the worst.
Category 3 is abnormal and predictive of abnormal fetal acid-base status. Requires prompt evaluation and intervention, often including expedited delivery. This includes patterns like absent variability with recurrent late decelerations, recurrent variable decelerations, or bradycardia, baseline below 110, or a sinusoidal pattern, which is rare but ominous.
And Category 2. The middle ground.
Category 2 is indeterminate. It includes everything not in Category 1 or 3-2. These patterns aren't predictive of abnormal acid-base status, but require continued surveillance and reevaluation as they could progress to Category 3. Most tracings fall into Category 2 at some point during labor.
So it's a clear classification system for guiding action.
Exactly. A universal rapid response language for clinical teams, streamlining critical decisions on seconds count.
Even before labor begins, especially in pregnancies with risk factors, there are a variety of tests to help assess fetal health and readiness, right? Antenatal testing.
Yes, allowing us to proactively monitor fetal well-being and intervene if necessary, rather than waiting for problems to emerge during labor.
What are some common non-invasive tests? Kick counts.
Fetal movement counting, or kick counts, is a remarkably simple yet powerful tool for daily monitoring by the expectant parent themselves.
How does it work?
There are different protocols, but a common one is aiming to feel at least 10 distinct fetal movements within a 2-hour period, usually done once a day during a time the baby is typically active.
And if they don't feel 10 movements?
A significant decrease from the baby's usual pattern or failing to meet the count threshold warrants immediate medical evaluation, usually starting with a non-stress test.
Okay, the non-stress test, or
Yeah.
NST. What does that involve?
An NST involves monitoring the fetal heart rate using external EFM for about 20-40 minutes, looking for accelerations in the heart rate in response to the baby's own movement.
So non-stress because you're not inducing contractions.
Exactly. We're looking to see if the baby's heart rate accelerates appropriately when it moves. A reactive NST, considered reassuring, typically shows 2 or more accelerations. FHR increasing by at least 15 BPM for at least 15 seconds within a 20-minute period.
And if it's non-reactive, not enough accelerations.
A non-reactive NST might indicate decreased oxygenation or other issues, but it could also just mean the baby is in a sleep cycle. It usually requires further evaluation, often with a biophysical profile or a contraction stress test.
Okay, the biophysical profile, or BPP. That sounds more comprehensive.
It is. The BPP is a more comprehensive scoring system, usually scored out of 8 or 10 points, combining an NST with detailed, real-time ultrasound assessments of several key fetal parameters.
What does the ultrasound look for in a BPP?
It assesses 4 main things over about 30 minutes. Fetal breathing movements, practice breathing, gross body movements, limb or trunk movements, fetal tone, extension and flexion of limbs or hand, and amniotic fluid volume, measuring the pockets of fluid.
And each gets points.
Yes, each of those four ultrasound components gets 2 points if present normal
Right.
or 0 if absent tab normal. If an NST is included, that's another 2 points for being reactive. So a total score of 8 or 10 is considered normal and reassuring. Lower scores, like 6 or less, are concerning and usually require further action, potentially delivery. It gives a holistic, multifaceted view of fetal health.
What about the contraction stress test, CST? You mentioned that earlier, too.
The CST is less commonly used now due to the efficacy of the BPP, but it's essentially a stress test for the baby. It involves monitoring the FHR response to uterine contractions, which are usually induced mildly with oxytocin or nipple stimulation.
What are you looking for?
We're looking to see if the baby develops late decelerations during the contractions. A negative CST, meaning no late decelerations with adequate contractions, is considered normal and reassuring. A positive CST showing repetitive late decelerations indicates potential uteroplacental insufficiency and is concerning, suggesting the baby may not tolerate labor well.
And of course, standard ultrasound, US, is used throughout pregnancy, too.
Absolutely. Ultrasound is the indispensable window into the womb, used extensively for various critical purposes. Confirming dating early on, the detailed anatomy scan mid-pregnancy, monitoring fetal growth over time, assessing amniotic fluid volume as part of BPP or alone, checking placenta location and determining fetal position, head down breech, etc., as the due date approaches. It provides unparalleled visual confirmation and is a cornerstone of assessment.
For deeper insights, particularly in higher risk situations or when screenings suggest potential problems, there are also invasive tests.
Yes, and the crucial role of genetic counseling alongside these. These tests provide more definitive answers but do carry small risks.
Like amniocentesis. What does that involve?
Amniocentesis involves inserting a thin needle through the mother's abdomen into the amniotic sac to withdraw a small sample of amniotic fluid.
When is it usually done and why?
It's typically performed after 15 weeks gestation. It can be done for genetic analysis, examining fetal cells in the fluid for chromosomal abnormalities like Down syndrome or other genetic disorders. Later in pregnancy, it might be done to assess fetal lung maturity by measuring specific components in the fluid if early delivery is being considered, or sometimes to check for infection.
What are the risks?
Risks, though small, typically less than 1% risk of miscarriage when done by experienced practitioners, include bleeding, infection, leakage of amniotic fluid, and very rarely injury to the fetus, a critical precaution. If the mother is Rh negative, RhoGAM must be administered after the procedure
Why RhoGAM again?
to prevent her immune system from developing antibodies against potential fetal Rh positive blood cells that might have entered her circulation during the procedure. This protects future pregnancies.
Okay, what about chorionic villus sampling, or CVS?
CVS is another invasive diagnostic test, but it's performed earlier than amniocentesis, typically between 10 and 13 weeks gestation.
How does it work?
It involves obtaining a tiny sample of placental tissue, the chorionic villi, which have the same genetic makeup as the fetus, either through the cervix or through the abdomen with a needle.
And its purpose?
Its main purpose is early genetic diagnosis, providing results much sooner than amniocentesis.
Are the risks similar?
The risk of miscarriage is similar to or slightly higher than amniocentesis, depending on the study and practitioner experience. There's also a small risk of bleeding or infection. There used to be concern about limb defects if CVS was performed very early, before 10 weeks, but that's less of an issue with current timing. And again, RhoGAM is essential if the mother is Rh negative.
So these invasive tests give definitive genetic answers, but with small risks. That leads us to genetic counseling. Why is that so important?
Genetic counseling plays a foundational role, especially when considering screening or diagnostic testing. Genetic counselors are trained professionals who help individuals and families understand their genetic risks. They assess risks based on age, family history, ethnicity, screening results. They explain complex genetic information in understandable terms. They discuss the benefits, risks, and limitations of different testing options, screening versus diagnostic, amnio versus CVS. They help interpret text results. And crucially, they provide non-directive support, helping individuals or couples make informed decisions that align with their own values and goals regarding their pregnancy.
So it's not just about identifying problems.
No, not at all. It's about providing comprehensive information, context, and support for informed decision-making. It's a vital part of navigating the complexities of modern prenatal care and genetics. #hashtag outro.
Wow, what an incredible journey we've taken today. From that single cell embarking on a precise dance of fertilization and implantation, through the astonishing week-by-week development of a fetus, all seamlessly supported by that intricate symphony of maternal adaptations and meticulous prenatal care.
It really is a testament to nature's biological ingenuity.
It genuinely highlights the profound resilience and breathtaking complexity inherent in human life, doesn't it?
It really does. In every single detail we've discussed today, from the tiniest enzyme reaction preparing sperm, to the intricate circulatory shunts that reroute blood, the placenta's multifaceted roles, the careful monitoring and prenatal care, every piece plays an absolutely vital role in ensuring a healthy beginning.
It really elevates your understanding of existence itself when you think about it.
It does.
So next time you hear a baby's cry, or maybe just pause to consider the vast potential within each of us, I hope you'll remember the astonishing, interconnected symphony of life that unfolds, often unseen, long before that very first breath.
That hidden world of development.
It really makes you wonder, doesn't it, about the sheer, almost improbable brilliance of it all, and how much is perfectly orchestrated down to the finest detail just to bring forth new life.